A breakthrough in the fight against Ebola as scientists say we can beat the disease. You're watching Roundtable. Good to have your company. I'm David Foster. Two new Ebola treatments are looking so promising that they're being tested on patients right now in the Democratic Republic of Congo, where the current outbreak is the second deadliest ever. One medical official announcing this month we can no longer say that Ebola is not curable.
There is new hope in the fight to stop the deadly Ebola outbreak. Two experimental drugs now show remarkable results in combating the virus, with high survival rates in large clinical trials.
Well, it depends on if they come in early or if they come in late. If they have a low viral load and they get this drug, they have about a 90% chance of surviving or a 10% mortality. If they come in late, it is not as good, but it's still better than no therapy at all.
In the Democratic Republic of Congo, where there's currently an outbreak, the drugs will now be offered in 14 treatment centers for all patients infected with the disease. Ebola has swept through eastern Congo since August 2018, leaving some 1,800 people dead. Since 2013, Ebola has killed more than 13,000 people in several African countries. Officials from the World Health Organization say the results are encouraging, but warn that the drugs may not be enough to end the second largest outbreak in history.
Let us get the conversation going. Joining us from Tessin in Switzerland, we have Daniel Bausch, who's director of the UK Public Health Rapid Support Team, which frequently works in Ebola-affected areas. We also have Dr. Derek Gatherer from the Biomedical and Life Sciences Department at Lancaster University here in the UK. In the studio, Robbie McIntyre, Global Media Manager at Save the Children, although I know, Robbie, the jobs do interchange. And in fact, you've got a different title. We'll talk about that in just a moment. And the human rights activist, Francine Mukwaya, who lived through an Ebola outbreak in the DRC slightly more than 20 years ago. Great to have you on the program. Derek, Daniel, let me just go to Daniel first of all. When we heard from Jean-Jacques Muyembe that Ebola was no longer incurable, was that a fair statement?
I think that it is a fair statement. There's a range of severity for all diseases, but certainly the response to this new treatment has been very significant, and it offers a lot of hope for people who, before this, for the last 20, 30 years looking at Ebola, we're probably not going to have a very good outcome. So it's definitely very promising. There's still a long ways to go. Looking
at some of the figures from the World Health Organization, the average mortality rate with Ebola, 50%. In the DRC right now, I think it is about 70%. That means that either 50% or 30% did not die on the whole when they got Ebola. So it was curable. What's the difference between being able to recover and being incurable?
We don't completely know why one person survives and another person dies. It may be various different things, how much virus a person gets infected with, what the route of infection was, how soon that they come to a care center, what other diseases they may have at the same time, their nutritional status, all things go into it. That's not any different from many other diseases, however, where there's different factors that come in as to whether a person survives or dies. But nevertheless, the results from the recent trial do show a very significant impact of getting a couple of the drugs.
Let's go talk to Derek now, because you have some concerns about the efficacy of these two drugs in large outbreaks. Am I right?
Yes, I think that there's two things that we need to consider. The first one is that the clinical trial, which recently went to completion, and that is great news that we have managed to get a clinical trial going to completion in the field. That revealed that, in fact, you have to dose the patients fairly early on in their clinical course in order to get the 89 to 94% survival rates that were reported. And those patients that weren't given the drugs in the early stage of the infection actually have survival rates of around about 60 to 70%, which is an improvement on what you would expect with normal clinical care, and that was a significant result in the clinical trial. But it does mean that many patients will still die. The second concern that I have really is about cost of the two drugs that turned out to be the best in the trial. They're both antibody therapies produced by a company called Regeneron, and I don't know how much it costs to treat per patient, but back in 2014, when another antibody-based drug, ZMapp, was much touted in West Africa, they were talking about $500,000 per patient, and only a handful of patients were treated with ZMapp. We didn't get clinical trial data on ZMapp in West Africa. This time around, we do have clinical trial data on ZMapp, and it hasn't done as well as the other two drugs.
So they are probably cheaper, but perhaps not quite as effective. We'll come back, if I may, in a moment to ask you about the way these drugs work and how they should be administered. But let's talk to people who've spent some time on the ground out there. And the point was made that you have to get treatment in early with these two drugs, REGN, EB3, I think it is, and MAB114. You have to get treatment early to make them successful. And the problem is persuading people to go and get treatment, Francine.
Yeah, the thing is, I mean, according to Dr. Jean-Jacques Muyembe, he said the medication they found, you can't prevent it. You can't prevent Ebola with it, but you can get cured 90%. That's him. I heard him. I mean, he had an interview on BBC. He said that, but you can't prevent it. And then what you're saying about how people don't want to go.
They don't trust either the drugs or the authorities.
There is a myth. There is a myth. People believe. We have to look about traditional. We have to look about custom and culture there. So, and also trust of the government. And people don't. In the Western part, because they face it so many times, they cannot believe in it. But people.
Well, part of the problem is they see people going in to get treatment and not coming out again.
Yeah, because of people. I mean, there's this stigma. If you go to the center and kind of like the whole village will abandon you, something like that. And the traditional is like, another thing is when someone passed away, in African tradition, precisely in Congo, the family have to bury the person. I mean, here as well. But imagine if they know that I'm going to that center, it's like a death sentence for them. So when they go there...
So how do you persuade them? Well, let's come on to this.
Yeah.
I'll come back to you in just a moment, if I may, Francine. How, Robbie, in areas like this, do you persuade them that actually, whereas previously they've thought going to the health centre was actually a death sentence because of the associated problems with going in and meeting other infected people, that now with these drugs, they should forget about, A, the infections in the health centres, because they're probably going to get better, and secondly, they should forget about old superstitions. How do you get around that?
It's not easy. It's a huge part of what Save the Children does, is communicating with communities to build trust. We've been working in the DRC since the mid-90s and built up good links with the communities.
You've got over 1,000 community leaders on board, haven't you?
Yeah, we are training up huge numbers of community health workers to go out and teach people about the symptoms, about where to get help. Also teachers. We're also talking directly to children to teach them about the importance of hand washing, hygiene, and what symptoms to look out for. In North Kivu, in Ituri, which are the two worst affected areas, 58% of the population are children. So it is definitely a children's emergency.
When I looked at the map of where Ebola has been spread over the course of the last, well, I think it was 1976 when it was first discovered, it's very much across a swathe of the centre of Africa. But let's get a scientific view on the fact that there are, here on my piece of paper, 4 different types of Ebola: Zaire, Sudan, Thai forest, and Bundibugyo. Are these drugs effective against each of those different types? Derek, first of all?
We don't really know if the drugs are effective because they've only been clinically trialled against Zaire Ebola virus, and in fact most of them haven't been trialled at all, whether in a full-scale clinical trial or in a casual trial against the other 3 species of virus that can cause Ebola virus disease. So unfortunately we don't have that kind of information. For the vaccines, We do know that the current vaccine that's in use against Zaire Ebola virus in the current outbreak does give some degree of cross-protection in laboratory studies against Sudan Ebola virus. So for the vaccines, yes, we have reason to be optimistic. I don't think there's any reason to believe that the antibody-based therapies wouldn't have some effect against other species, but we simply don't have the clinical data.
Daniel, one of the ironies of this is that the efficacy of these drugs has been able to be proven because so many people have contracted the disease in DRC.
Yeah, that's right, and that's the challenge with these sorts of situations when we have a drug or a disease like Ebola. The only time and place that you can do a trial for these to see if they work is when you have an outbreak, and these outbreaks are occurring in the most difficult areas of the world. And they're ironically easier to show a difference when you have a high mortality rate, when lots of people die of a particular disease. You can see whether there's an effect, and so that is one of the things that has been enabled us to see the effect. I'm not sure that we would have great promise on these particular antibodies in treating other species of Ebola, because those antibodies and the drugs were designed specifically with the Zaire species in mind. That is the most severe of the species of Ebola and the one that most recently occurs.
Okay, so you work for the Rapid Support Group, the Public Health Rapid Support Team. If you're going into DRC or you're going into other countries, let's say, where it's proved to be working, like Uganda, Sierra Leone, Liberia, Sudan, all of which have had cases of Ebola in the past. What is the price of getting this sort of drug to the people?
The price right now, and it was quoted as millions of dollars or pounds for a given patient. It should be clear, I think, that first of all is not the cost of the drug per se. That's not what a pharmaceutical company is being paid. In fact, all the pharmaceutical companies and the products in these trials have been donated. That takes into account the very laborious and resource-intense measure of trying to put in place the care facilities, the trained healthcare workers, the IV fluids, the tubing, the protective materials.
All right, even if it is hundreds of thousands of dollars rather than millions, that is something that people in these poor communities can ill afford, or the governments in these countries can probably ill afford. So what's going to happen there?
What I would foresee in the future, and first of all, we have to recognize that we only have results of the trial yet. We don't have an FDA or EMA or a regulatory agency that's approved these drugs, and we don't have a commercial supplier yet on a large scale. What I would foresee once we get to that point is something that most likely the cost of these drugs and the therapy would be added into the costs that we usually look for in donors when we have an outbreak. And so if we're looking normally for, these are very costly events. If you say it costs $100 million to respond to an Ebola outbreak, and it actually for this outbreak, it's much more than that we would have to add in the cost of the drugs and administering the drugs to what we look for from donors when an outbreak occurs.
How do you provide aid groups with the tools they need to get this to the right people? Derek, can I ask you that one?
Yeah, one of the most important things is what we call the cold chain. So the cold chain means that we need portable refrigeration units that are reliable and in which you can store drugs and other necessary clinical materials which are sensitive to heating up in the African tropical sun, and keep them at 4 degrees so that they'll stay active. And you need to be able to get that cold chain to all of the places where the outbreak is occurring. So that means not just into the treatment centres, but out to the small villages and so forth where we're seeing the disease spreading. So cold chain is the most important thing that can be done with a view to making sure that we can get the treatments to the people that need them. In general, though, I would think that the looking forward into the future, perhaps the best strategy is to move to mass vaccination program, and we've seen in this particular outbreak a ring vaccination strategy, which means that you vaccinate the contacts of cases and then the contacts of contacts. So in general, you're expecting to vaccinate perhaps 50 to 100 people per case, but that's all very well in small outbreaks, but in large outbreaks, a ring vaccination strategy can quickly balloon into something very large.
I mean, when you're saying about the vaccine, all that is good, but the thing is, my problem is that the misinformation is there. The politicians are manipulating the people. Because Ebola in Congo is not only just a disease, it's also political. The politicians are manipulating people. And there's a lot of, like I stated before, lack of trust. Also, for me, the first thing is to educate people. People need to be educated, being trained.
But that isn't the scientist's area, though, is it? That is something you would have to take up as an activist with the people who run your health authorities.
I know, definitely, but the thing is, if you come with vaccine, then you're giving people, we just saw it now, what's going on now in Beni, Ebola started last year. People don't want to take on the medication they're giving them because they don't trust it. They really don't trust you. Know what you are on the field.
Well, they've trained up 1,000 community leaders, yeah?
Yeah, it's really hard.
Is it working?
Now that people are local community are involved, then people are kind of like trusting a little bit. But beginning, I know the vaccine is so important and all the medication they found the cure, but the local community need to be involved. People need to be trained to trust that vaccine.
But, okay, I'm asking you whether you think that is working, and the same question to you, Robbie, because on the ground, are you managing to get through?
It's
Francine
working.
First?
It's working now. It's working because I've been watching, Dr. Jean-Jacques Muyembe, all the video he's doing in local language and stuff. It's working because of a bit of trust now. And then also people are kind of, it's not myth, it's actually real disease. Dr. Muyembe's been in, when Ebola happened in Kikwit, I was really young. I've seen people die, and I've seen people also survive. I was about in my primary school. I know it's like yesterday, but I've seen like my friends' fathers who were doctors, they passed away, and some of them survive as well. But, I mean, that's why that trust, that's why the president of Congo, the present president, Felix Tshisekedi, got Dr. Muyembe involved, because we knew it's so important someone with experience with all the NGO, like a WHO, or the NGO, the big organization, together with the local community.
Are you getting through to the local community and telling them, look, a breakthrough's been made, you've got to trust us, you've got to trust the doctors?
I completely agree with what Francine's saying about the importance of this. I do think that we're getting through, but it's a slow process, and also it's one which needs more resources to be given to it. So we can't be complacent when we see that there are new drugs which are having some success. As has been mentioned, it's only if people are treated early that the survival rate is really going hugely up. And the only way people will be treated early is if they trust to go to health clinics, if they know what to do and they believe what they're being told. And as you've said, we are reaching huge numbers of community health workers, of teachers, and it is about getting those people who are trusted in the community to talk to their peers and talk to other people in the community that will build the trust. I was in Liberia in 2014, and I was there during a period where the number of cases started to drop. And that was partly because of clinics treating people, but a lot of that progress was because of reaching out to communities. And you would see that communities would start to trust, and they would start to do the right things. They would start to go to the right place to get help, and they would start to adhere to quarantines of 21 days. And that stopped cases from spreading, and it stopped.
Well, this is something I want to get on to with our two scientists. Daniel, let me come to you first of all in terms of the spread of the disease. Derek, I'll come back to you, asking more about a possible vaccine. But once again, looking at my map of where Ebola cases have been since 1976, it is Central and West Africa. You could almost draw a line pretty much slightly north of the equator, and that would be where it is. What is to stop the disease moving from these very particular areas?
So we think, first of all, that Ebola viruses are maintained in nature by certain types of bats. That still needs to be confirmed. And so the endemic area, or the places where we would have natural transmission, are probably the places where those sorts of bats exist and are infected with Ebola virus, which obviously is in sub-Saharan Africa and various places. But more important than the science or ecology of the disease is really where a particular introduction takes place. You know, if you look at the places where we've had large Ebola outbreaks in various places in the Democratic Republic of the Congo, Liberia, Guinea, Sierra Leone, and some of the places in northern parts of Uganda, these are places, there's no surprise, it's where the public health systems have been degraded from years of civil unrest and civil war. And so it's not so much just about the ecology of the science and where a virus gets introduced. It's what happens once it gets introduced. Are there gloves and clean needles and water and soap in a hospital? Is there a healthcare system and a laboratory system that can detect and diagnose a case rapidly? And where there's not, then we see large outbreaks occur. And consequently, where there are, when we have the occasional imported case into the United Kingdom or into North America, where we take it for granted that there are gloves and clean needles and soap and water and all the protections that we need, then we don't see large outbreaks. So it's as much the social, economic, and political determinants as it is the scientific one.
And I'll come to you, Francine, in just a moment to ask you about the hope for your family who are out there, who may be looking at this and thinking, well, actually, you know, we may be able to eradicate it. But let's put that question first of all to Dr. Gatherer. When you talk about vaccinations and you talk about antibodies, I have a picture in my mind of you being able to recreate the virus to a lesser extent, inject it into people so that they then have an immunity against it. Would you have to harvest those antibodies from people who have already had the disease?
The current drugs in the clinical trial are based on antibodies that were originally harvested from people in previous outbreaks. In fact, going back to the 1990s, for a vaccine, you don't need to harvest anything from a patient. The vaccines that are currently in use are recombinant vaccines, which means that they contain one Ebola protein, which is vectored into a harmless virus. So we use a VSV virus, which is a virus that doesn't cause disease in humans, that bears a single Ebola protein. You inject that into an individual. There's no danger of any disease developing, but they develop a very strong immune response against the Ebola protein that's in that.
And are we close to that or already there?
But that's the strategy that's used for the current vaccine, the one that has had several tens of thousands of doses delivered in the Congo, and which seems to be working very well, up to 90% protection in the people that have received it. So we could progress to a mass vaccination with this vaccine or a similar vaccine, maybe perhaps a better developed one in the future, much as we do for many other diseases in Africa. We have had lots of success with mass vaccination programs against polio, for instance, which has now virtually disappeared, against measles, and also against things like yellow fever in parts of Africa.
Would you be able to eradicate it?
I think eradication is a difficult term, because that implies that the disease will disappear completely, like smallpox did. And in fact, smallpox only had humans as a host. So therefore, once everybody was vaccinated against smallpox, we could eradicate it. Ebola virus, as was mentioned earlier on, has a natural host, possibly in fruit bats, possibly in some other bats, and it probably will always be there. So there will always be the danger of Ebola virus hopping over from its natural reservoir into the human population.
If you'd ask be able to contain it, which would be very good news indeed. Francine, is this news being taken cautiously back in the DRC, or are people, you know, as Derek was saying, you know, with inoculations proving to be so effective, with this treatment out there now, do they think the worst is over?
Yeah, a lot of people. We kind of decided in Congo with a lot of, instability. We've been having a war for years. So we have a lot of activist movement, and the youth, like the group, like my group I'm part of, and other. We're trying to raise awareness, and then we kind of been using that with hashtag and all that. And then a lot of people are we're getting there, like my colleague just said. We said we have to use the youth because majority of that country are people under the age of 30. So I think there's a hope there with the people trust now, because like I said it before, because of local leaders are involved, the local leader, the chief, the traditional chief, and all people are involved with the NGO. So I think there's a hope. There's a hope because I saw it in Kikwit. There were people, even my brothers, my cousin, they were involved with the Médecins Sans Frontières, Doctor Without the Border, and to actually support them during the 1995. I was really young, but I can still remember it like yesterday.
Well, you were isolated, weren't you? You weren't
Yeah,
allowed
they
to go
put
into the
them in
capital,
they put them in a specific hospital called, if I can, General Hospital, Hôpital Général de Kikwit, like General Hospital of Kikwit. So they put them there, and all the community got involved, and they support them. And of course, a lot of people die, but some people survive. I don't want to say the name of the people, but I know 2 doctors who survived Ebola in Kikwit. There were people who survived and Ebola because of that. So there is a hope as long people trust what they just found. If people don't trust, because it's going to be difficult. Consider the eastern part of Congo with all the war. We have to look at psychological issue, and there's lack of trust in that part of the country. Yeah, and then instability, and the militias who are actually burning all the centers and things like that. So it's a bit
Francine,
complicated.
we've had your expertise on those issues on another roundtable when we were talking about the Congolese election. But hope, a little bit of hope for now. Robbie, thank you. Francine, thank you. Good luck with all your work with the community leaders. And to our 2 experts, fabulous news, perhaps a little bit early to sort of hang out the bunting and to sort of start cheering in the streets, but it is a step forward. Having heard from the Public Health Director, Jean-Jacques Muyembe, as you mentioned him many times, from now on, he had said, we will no longer say that Ebola is incurable. Thank you for watching. Thank you for taking part. I'm David Foster. I hope to have your company next time. Goodbye.